Hello and welcome to another Supporting Client Health and Wellness class presented by the Far Northern Regional Center's clinical team. My name is Jen Badger. I'm an RN and I work for Far Northern in the Reading office. And on the call with me today is Katie Taylor. Katie, I don't know if you want to say
Hi,
hello.
sorry. I am one of the nurses out of the writing office.
And then also Nellie Camarina is with us today.
Hi, everyone. Thanks for joining us.
Hi, Nellie. So I'm just going to roll right into it. This is a kind of a pretty thick topic. There's a lot of information. So as you may be aware, we're doing our Fatal Five series. The Fatal Five is the top five conditions that cause death for individuals who are intellectually disabled or have a developmental disability. And so this class is going to be on bowel obstruction. If you've been attending these classes for a while, you've probably gone to a few classes on bowel obstruction. I did go through and change this class up a little bit. I added some other information. So there will be some new information that you can glean from today's class. And hopefully you can add it to all the knowledge that you've gained from our previous classes. And you're all going to be experts on bowel obstruction by the time we're done with this. So I apologize. I have my phone on Do Not Disturb, but for some reason it continues to ring. So I'm sorry about that. All right, well, let's go ahead and just keep going. All right, so the objectives. This just gives you an idea of what we're going to talk about over the next hour. So we're going to do a very brief overview of GI anatomy, talk about what constipation is, what causes it, what the symptoms are, the complications of constipation, which would be like bowel obstruction, and also the prevention and management of constipation and the care provider's role. If we have time, I will go into dietary considerations, but I'm not going to spend a lot of time on that. I didn't prioritize that for today's class. Okay, so here is a basic picture of the main organs of the digestive system. And the digestive system consists of two parts. And the first is the alimentary canal. And this is basically where food goes in, travels, and then comes out. It includes the mouth and then the esophagus and the stomach, the small intestine, the large intestine, and the rectum and anus, where stool is expelled. And then the other part of the digestive system is the accessory organs. We have salivary glands and our teeth that we chew with, our pancreas that secretes insulin, and the liver, which cleanses the blood, but also excretes bile through the gallbladder into the small intestine that helps process and digest fats. But all of these parts make up our digestive system. And as you can see, it's honestly really complicated. There's quite a lot of organs involved, and the digestive tract itself is really very long. So, skipping ahead, we're just going to go straight to the large intestine because that's going to be our main focus today. The large intestine, as you can see on this picture, it starts in the lower right-hand corner, down here in what's called the cecum. That's where all of the foods and fluids that haven't been absorbed by the small intestine, they end up going into the large intestine there. And then they go up the right side, and that's the ascending, which means going up. And then they go across the transverse colon and then down the descending because it's going down. That's on the left side. And then there's the sigmoid colon, which is the part of the colon where the stool really becomes the most solid and formed and ready to be expelled. And then the rectum, which is just part of that process of having a bowel movement. The rectum is very involved in that. So in the large intestine, waste products from food are collected and processed and turned into feces. The main role of the large intestine is to reabsorb water out of the stool. So the feces and stool that is going into the bottom right side over here is very, very liquidy. And so as the stool travels through the colon is pulling fluid out of it and making it more solid. And so it's, more of a mushy texture in the transverse colon. And then as you get down to the descending colon and sigmoid colon, that's where the stool has the least amount of water left in it. And so it's more solid, which makes it easier for the body to propel it out. The large intestine can absorb certain vitamins, but it's not really considered a hugely important part of absorption of nutrients. Really, it's mostly absorbing water. It processes that undigested material like fibers from vegetables and whole grains and compacts that into the feces. And then it stores the stool or, is the holding place for it until the individual is ready to go and have a bowel movement in the restroom or wherever they do that. So what is constipation? Well, the definition of constipation is having 3 or less bowel movements each week. But, most people go to the bathroom and have a BM every 1 to 2 days. Some people, they always go 3 days or so at a time. But any longer than that between bowel movements, and you really have to start getting concerned about the body's ability to expel that stool without causing some issues. Stools are hard and dry and difficult to pass when someone is constipated. This picture is a good demonstration of how stool sort of piles up down at the end. The bowel is constantly peristalsing, so it's moving in a rhythmic pattern and it's kind of moving the stool along. And when it starts over here, as we said on the right side, it's very liquidy. It's not all stuck together. And then it starts to become a little more solid. And then as it goes down the descending colon, it ends up being more and more solid. And down in the lower part, if somebody is constipated and they're having trouble having a bowel movement, and they go a longer duration without having a BM, then the stool starts to pack in there and it starts to just build up. And that dilates the colon wall because there's pressure building where it's getting packed in, but it also makes the stool much larger in diameter, which can be difficult for the colon to contract and push it out. So generally, when somebody is having a hard time passing their stool, they're straining a lot, etc., then that's a good chance that they are constipated. One way we look at bowel movements to assess if someone might be having constipation or not is, using the Bristol stool chart. Now, I know we've looked at this before, and it's a great chart. I don't know who invented it, Bristol, I guess, but they were pretty smart. So Basically, I'm going to start at the bottom. So type 7, or this is like watery, there's no solid in there. And that is like someone who's having diarrhea. So diarrhea would mean that the stool is passing so quickly through the colon that the colon doesn't have a chance to pull all the water out and make it solid. Um, so as these types get more and more firm, you get to what is really more of normal bowel movements, right? A normal bowel movement should be um, firm but soft and should be all stuck together or close to it, right? That's about the right consistency for your bowel to function very smoothly and be able to have bowel movements with regularity. When we start to get worried is when we see stools that look like a lot of small pieces of stool have been packed together, and you'll see what's like cracks on the surface, and those pieces of stool were pretty hard. They didn't really mesh together into a nice solid bowel movement. You can also have like stools that are just really lumpy, like almost like parts of them are hard and parts of them are soft. And then, of course, when somebody's having a really hard time, they may only be able to pass very, very tiny little balls of hard poop. So if you see these, like the top two or three, or the client sees those, then that could be an indicator that we need to start looking at ways to help that person with their bowel movements. It may be something very simple that you can just, like encouraging more fluids or more fiber in their diet, or they may need to have like a PRN. So here you can see these are the common causes of constipation. So this applies to everyone. So for all of us, we can be constipated if we're not drinking enough water, or if the fluids that we choose to drink are dehydrating more than hydrating. For instance, fluids that are very, very high in sugar or very high in caffeine are not going to be very hydrating for you, because sugar and caffeine both cause you to lose water. So we want to make sure that we're all drinking plenty of regular water, or maybe like an electrolyte drink or something that's not going to be dehydrating. Um, Also, an unhealthy diet can contribute to constipation. Eating a diet that's really high in fats and fried foods and carbs and not very much fiber is going to be more constipating than someone who's eating a lot of fruits and vegetables and whole grains. Medicine is a very big culprit in constipation, and lots of medications have side effect warnings that they cause constipation. It doesn't mean that they all do, but some medicines in particular are well known for causing severe constipation. And that's something that it's really important that we're all aware of with our clients, so that we can make sure that while they're taking that medication, that we're also watching their bowel function and making sure that we're addressing that at the same time. Pregnancy can also be a common cause of constipation. Being pregnant and having a fetus inside of your belly, it can put a lot of pressure against the colon. It can make it difficult for stool to pass. So that can be hard. Also, stress can be have a big effect on constipation. Any kind of stress and anxiety, what it does is it kicks on your sympathetic nervous system, and it decreases the autonomic nervous system action, And unfortunately, part of that action is we stop digesting and our GI tract kind of slows down so that your body can divert energy towards whatever you are having anxiety or stress about. So it's really important that we work with clients on relaxation techniques, stress reduction, stress management, that we maybe talk with them about things that may be bothering them and help them troubleshoot ways to address those problem areas in their own lives, because reducing stress is going to be helpful for their overall health and wellness. A change of scenery, so a big move, going on a vacation, those kinds of things can also contribute to constipation. A lot of that is just simply that people get out of their normal routine. Rising age, so as we get older, people have a harder time managing constipation. It can be more difficult as we age to stay hydrated. It can be hard to eat a healthy diet, and older adults tend to take more medications as well. And then a sedentary lifestyle. It's very important to get active and be up and moving and do exercise. Just taking a walk after a big meal can really help with your digestive tract and getting things moving. And when you think about this, consider some of our clients who have issues with immobility, like maybe they are unable to walk. Maybe they are bedbound. People who have immobility like that are not going to be able to take advantage of the exercise and activity to help them have a bowel movement. So it is one thing to consider as being a risk factor for constipation. So here are some diagnoses that can cause organic constipation. In other words, the body has a condition that makes it physically more difficult for them to have a normal bowel movement. So many of these are conditions that we see in our clients. Some of them are developmental disabilities or congenital issues such as spina bifida, cerebral palsy, Hirschsprung's disease, Down syndrome, Prader-Willi, celiac disease, anorectal malformations, also any kind of brain or spinal cord injury, anything that affects the nervous system and the functioning of the nervous system is also going to affect the function of the bowel. And that can include things like ALS or having a stroke, multiple sclerosis, Parkinson's disease, Guillain-Barré, dementia also, for multiple reasons, not just because there's effects on the neurological system, but also because a person's mentation may make it difficult for them to respond when their body tells them that they need to go use the restroom. People with diabetes who have nerve damage associated with it can have dysfunction of that autonomic nervous system. There's also a condition called pelvic floor dysfunction, which has to do with the individual's ability to relax the muscle that holds this part. I don't know if, hopefully you can see my arrow, but there's a muscle right here. It's kind of like a sling, and the bowel kind of goes over it. And when you have a bowel movement and you're sitting on the toilet and you're relaxing your muscles to go to the bathroom, one of the things that happens is that muscle relaxes and lowers and allows the stool to move, so it doesn't have to go around a 90-degree corner, basically, right? So it can come out easier. So some people have pelvic floor dysfunction, and they actually have therapy for that, where they can learn how to relax that muscle properly to allow themselves to have a bowel movement. And also complications from surgery can cause difficulty with having a good bowel movement. So just a slide here on medications that can cause constipation. As I said, if you opened up a drug guide and you looked at any random medication, you can almost guarantee constipation's going to be listed. But there are certain medications that are well known for causing constipation and even for causing bowel obstructions. So the number one is going to be any kind of opiate pain medication. So this is your codeine, your hydrocodone, oxycodone, morphine, Dilaudid, any of those. Any kind of an opiate is going to not only does it relax you, but it relaxes your bowel, and it can keep the bowel from really peristalsing almost at all. So you have to be really cautious when someone is on opiate pain medications. And that would put them in the very high risk category if they take those on a regular basis. Antipsychotic medications are also well known for causing constipation, and clozapine or clozaril specifically is known for leading to bowel obstruction. One of the things that is so important is if you have a client who takes antipsychotic medications, we want to make sure that we are following a care plan to monitor their bowel function and addressing any issues quickly. Other drugs that are common for causing constipation, alendronate is a drug used for osteoporosis, cancer treating medications. Iron is well known for causing constipation. Some antidepressants, anticonvulsants, and mood stabilizers, which of course, epilepsy is one of our eligible diagnoses. So a lot of our clients are taking anticonvulsant medications. Anything that's to decrease nausea or intestinal spasming. The whole role of those drugs is to stop the GI tract from moving around too much, right? We don't want to throw up, and so we take something that's going to stop that contracting and spasming of the stomach or the esophagus. If you take something like dicyclomine, which is also called Bentyl for irritable bowel spasms and stuff, that also same kind of thing. You're stopping peristalsis by taking it, so you're actually leading to the same problems that can cause constipation. So we want to be really aware of that. Some blood pressure medicines and cardiac meds, any of the diuretics like Lasix or hydrochlorothiazide, those are medications that make you urinate more. So they're trying to dehydrate you, if you will. And by doing that, you also are going to be at a higher risk for getting constipated because you don't have as much fluid in your body to keep that stool nice and soft. Allergy medications and acids and also monoclonal antibody drugs can cause constipation as well. So the symptoms of constipation, I guess this slide might be a little early. I probably should have put another one in. But the one thing we want to pay attention to in our clientele in particular is our individuals who are maybe nonverbal, maybe they're unable to clearly express when they're in pain or having discomfort. So this is the CNPI. It's a checklist of a way to basically chart what somebody's symptoms may be, here they have it divided with movement or at rest, because pain at rest is a different problem than pain when you move, right? If you have pain when you move, it's usually like related to a limb or something or an injury. Whereas if you're in pain and discomfort when you're just laying there not doing anything, then that can be something far more serious. So some nonverbal pain indicators also include, like, if their pulse is very fast, if they're breathing really quickly. If you check blood pressure on your clients and their blood pressure is very high, that can be an indicator that they are in pain or uncomfortable. Often, individuals will become nauseated. They may start sweating. Pupils will dilate. If they're having pain at night, they may not be able to sleep. They might be restless while they're asleep. If they're sleeping and they're tossing and turning and they can't get comfortable even while they're out, that means they probably are in some sort of pain or discomfort. And then we always want to watch for changes in behavior. If somebody is holding tension in their muscles, if they have their fists clenched, if they are doing some kind of repetitive behavior that's something different for them. Self-injury can also be an indicator of pain or discomfort, because they're not sure how to respond to it. And so they're trying to do whatever they can to distract themselves from that discomfort they're having. And sometimes self-injury is the only way they know how to do that. Also, if they are isolating all of a sudden, they don't want to join in with people. They're hiding out in their room. They're in the fetal position in bed. Those are all things that could indicate that somebody is having pain or discomfort. And of course, if we know that that they are at a risk for constipation, we want to always consider that maybe they're having trouble with that. Other nonverbal, sighing, gasping, moaning or groaning, crying out with movement in a certain way or touching something, facial grimaces, winces. All of those things can be clues to us that the individual is having some kind of pain or discomfort. And so we want to just be aware of those things and pay attention to them when we see them in our clients. So the signs and symptoms of constipation or of a bowel obstruction include like the differences in the stools, like we talked about. It also can cause abdominal pain or cramping. They could be straining, having difficulty passing stool. If they strain a lot, it can lead to bleeding from the anal area. Another indicator that something may be wrong with their gastrointestinal system is that they are suddenly not interested in eating or drinking anything. Their abdomen may get hard and distended. It might protrude out kind of oddly. And then having the inability to pass gas, that is a big red flag. Because even someone who has constipation can usually pass gas. But if they have a bowel obstruction, they are not going to be able to pass any gas. And that, as I'm sure you know, can be extremely painful and uncomfortable. And then, of course, if they start vomiting what looks like digested food or anything that smells like feces, that is a big, big problem right there. That would be an emergency, because that would mean things are not going in the right direction. They are coming up the wrong way. And so we want to make sure to get those individuals to an emergency room ASAP. So, what are the complications of constipation? There's actually quite a list here. And some of these we're going to go into a little bit deeper, but hemorrhoids is probably the most common constipation complication. A hemorrhoid is a swelling of the tissue around the outside of the anus, or sometimes they're up inside of the rectum. The tissue gets swollen and irritated because they've been straining, which causes a lot of pressure down there. And there's hard stool that's pressing against the walls of the rectum and it causes inflammation and swelling. And those are what we call hemorrhoids. Anal fissures, those are small tears that can occur around the anus, and fissures are extremely painful. It's, it feels like you are like there's a piece of glass in your BM. If you have an anal fissure, an anal fissure is not an emergency, but they're very uncomfortable. So it is something that if someone is complaining of, that sort of sensation when they go, they probably have an anal fissure. And so most of the time, for hemorrhoids and fissures, a simple like preparation H cream or something can be very helpful. Any kind of rectal bleeding can be a complication of constipation. Fissures can bleed. Some hemorrhoids can also bleed, sometimes quite a lot. So any rectal bleeding, though, we want to definitely have that person get checked out by a doctor. Another complication, especially of chronic constipation, is diverticulosis, which if it gets infected, can turn into diverticulitis. And this is just these are changes to the wall of the colon where it's, because it's been so frequently packed with stool really tightly, and that stool moving up and down in the colon can cause changes in the surface, and you get pockets where some feces will stay in the pockets that are on the sides of the colon, even though the stool is moving through. And that can lead to inflammation and infection or diverticulitis, which can be very dangerous. So signs of diverticulitis would be like similar to constipation, abdominal pain, discomfort, sometimes having some pus or, what's the word? Like secretion that's mixed in the stool that's coming out from that infection. And that is something that is treated with antibiotics. So they really would need to be seen for that as well. Another complication of chronic straining to poop is a rectal prolapse. And that is where the rectum basically slides out a little bit from the rectum comes out of the anus, and it kind of balloons out and looks like a little red tomato sticking out of their bottom. And so that is not a good thing, right? And we don't want to just push it back in or anything. We want to make sure that that person is evaluated by a physician, and then they can advise on what to do to reduce that prolapse. It rarely requires surgery, but sometimes it does. So it's definitely something that they would need to have treated. And then the three worst of the complications are the fecal impaction, bowel obstruction, and bowel perforation. And we're going to talk more about each of those. So fecal impaction is where a large quantity of stool gets basically stuck in this area of the bowel. It's usually kind of down here and takes up this whole side. But I've seen pictures, like life pictures of people who their whole colon was just huge and packed with stool. Because if nothing is getting out of the exit and the body is still packing poop in every day, all the time, it's just going to get worse and worse and bigger until something moves. But it can be extremely difficult for that to get moving once it is in that state. And so it sometimes requires quite a lot of intervention to get that fecal impaction out of there. The signs of that you're going to see would be having a lot of pain and rectal discomfort, the feeling of like something's in there that's big, anorexia or not wanting to eat because things are not moving. So, they're going to start feeling nauseated. They may be throwing up. Usually there's complaints of abdominal pain, especially if you press lightly on the abdomen on that left side. It's usually very painful, and their abdomen may be very firm in that area. They can also, though, and this is how people get tricked, because they can have paradoxical diarrhea. So what happens is, because the stool doesn't seal off the colon, right? There's still little spaces where liquid stool can get around. And so they may be having liquid stools. They may be having liquid stools frequently. And, in your mind, you're thinking, oh, they're having diarrhea. They're not constipated. They have the opposite problem. But in reality, what's happening is they're so constipated in the area of the colon where all of the firmer stool is, that the liquid stool over on the other side is making its way around and it's just coming out. And so that can be very deceiving. So if you have someone who's complaining of having a lot of liquid diarrhea for a long time, and that they have a history of constipation or they have some risk factors, it might be a good idea to have them seen just to make sure they aren't actually dealing with an impaction. Having all that stool in there can also cause urinary symptoms because the pressure on the bladder. And then when it's been there for a bit and they're really feeling bad, they can end up with a fever and tachycardia or rapid heart rate, because there's a very high risk of becoming septic when someone has a fecal impaction. And then bowel obstruction. And this is the one that is in our fatal five, right? A bowel obstruction is where there's part of the bowel is just not working at all. Things are not going through. And usually when this happens, there is some tissue in the bowel, and it's usually in the small intestine, even though bowel obstructions are generally caused by constipation, but they are usually found in the small intestine, which is
You
really
took your
interesting.
medicine at lunch? Oh, no.
Sorry, I had to mute Maxine. So what happens though is this part of the bowel stops moving anything through at all. And so fecal matter and liquid, all of that builds up on the other side. And it causes pressure. And that pressure can cause necrosis of the tissue, and necrosis meaning the cells of the tissue actually die. Sometimes when individuals go into the hospital and they have a bowel obstruction, they can be given lots of laxatives. They can, get a NG tube to take things out of the stomach so they're not throwing up, and we're not, putting things in when it's not going to go through. And sometimes they resolve on their own. But when there is necrotic tissue, then in that case, the doctor usually needs to go in and actually do what's called a resection, where they remove the section of the bowel that is dead, if you will, and then they sew the small intestine back together. Unfortunately, sometimes this can be a really big section that is necrotic. I mean, I've seen people end up, I think the small intestine is like 17 feet long. Maybe not that long. It's long though, but I've seen where they've had to remove sometimes almost the entire small intestine. And unfortunately, that's not congruent with life. Because the small intestine is the part that absorbs all of your nutrition. And so it can be very, very dangerous for folks. In addition, if they aren't able to sew that piece of the bowel back together, then they have to put in a colostomy. We'll talk about that some more in a minute. The main things, again, very similar symptoms, right? We're not eating or drinking. We're nauseated. We're throwing up bile, which is a green liquid, or digested food that smells like poop. And at this point, we cannot pass gas. So the abdomen gets very distended. It's very hard. And it's just a really painful condition to be in. And it's definitely an emergency. When we suspect a bowel obstruction, or even just severe constipation, we want to get that taken care of immediately, because we don't want to end up in a situation where someone needs a colostomy or is not able to survive. Now, the other one was bowel perforation. This is the last of the complications we're going to go over today. So the way a bowel perforation occurs very similarly, we have the bowel obstruction. You can see here in figure 2, where this part of the bowel is not moving at all. And so stuff is backing up. And unfortunately, sometimes this part of the bowel gets stretched to the point where it cannot contain it anymore. And what ends up happening is a perforation, or basically a hole. A hole appears in the bowel, and then we have leakage of fecal material into the peritoneal space. I'm just going to ask that everyone please stay muted. Thank you. So if you have a perforation and this fecal material gets out, it's your peritoneal. This is the space that all your organs are sitting in. And that space is sterile. There's no bacteria or anything in that area of your body. But there's lots and lots of germs inside of this fecal material. So if that gets out through a perforation and into your abdomen, you can end up with a massive infection of the peritoneal space. And that is extremely dangerous. If there's a perforation, what you would see, other than the other symptoms that might be occurring because of a bowel obstruction or appendicitis, right? We hear about appendix bursting, same sort of scenario. But you'll see a sudden worsening and severe abdominal pain, bent over, rigid abdomen, crying. I mean, it's horrible, horribly tender. They will spike a very high fever because of the bacterial infection. And that can cause chills. They may have nausea, vomiting, all of the things that go along with infection and sepsis. So these are just conditions that we want you guys to be aware of because we want to make sure that you're ready and prepared to seek help if something like this happens. So the treatment for obstruction, again, they may be able to, replace fluids through the IV to help lubricate the bowel and increase that liquid in the stool, get the person really hydrated. They're going to give medications for pain. They may also give medications that help with motility and antibiotics to prevent or treat infection. Oftentimes, one of the first things they do is put an NG tube in, and that's a tube that goes through your nose down into your stomach. They hook it up to suction, and it actually keeps your stomach totally empty. And the whole goal there is to prevent you from repeatedly throwing up, which can then, of course, put you at risk for aspiration and lots of other problems. And then the treatment would be surgical resection of necrotic tissue. If they find that, they will do usually a CT, and if they see necrosis, they're going to probably do surgery. It's probably going to be done right away. They don't wait on these. These are true emergencies. And then if they cannot resect the colon or the bowel back together, the individual may end up with a colostomy. And here's a picture of what a colostomy looks like. And that's where they have their bowel connected to the front of the abdomen. And it's a nice little opening that's called a stoma. And then they have a bag that they stick on there, and that bag catches their stool. Colostomies can be temporary sometimes to allow for healing, and then they'll go back in and put the bowel back together. But a lot of times they're permanent. And this has a massive effect on the client. It's a huge change in their life and their lifestyle. Oftentimes they need to go into a different living situation. They need nursing care. And then they have, this bag that they have to wear all the time, which can be, of course, a real hit to their dignity and feelings of self-esteem. So it's all around a really difficult situation, and one that we definitely want to try our best to avoid. Okay, prevention is the key. We want to ensure that individuals are receiving high fiber foods in their diet. We want them to avoid eating highly processed foods with low fiber content, drink lots of fluids, reduce stress, stay active, plan activities that promote movement, and anticipate potential constipation and be proactive in prevention. So don't wait till there's a problem to do something. If you know somebody is being prescribed a bunch of meds that cause constipation, then, it's a good time to talk to the doctor about, okay, what can we have available for their possible constipation if they have it, that kind of thing. They can also, a provider can give you also recommendations on diet and other types of things like prune juice and supplements and things that might help as well. So we want to make sure we're establishing bowel routines. So we want to assist individuals to establish a schedule. We want to encourage bathroom breaks, 20 to 30 minutes after meals, and allow plenty of time for those bathroom breaks, and work with the doctor to have a bowel protocol in place. We want to administer stool softeners or laxatives as prescribed, and know that a bowel protocol should be established for anyone who has a history of constipation, a history of a bowel obstruction. If they're prescribed laxatives, stool softeners, fibers, supplements, we should have a bowel protocol put together. If they take medications that are known to cause constipation. And then we want to be sure that we're tracking bowel movements, frequency, consistency, and volume on clients. So what are the medications that manage constipation? I'm going to go through these slides really quickly, you guys, because I know we only have 7 minutes. So basically, we're working with things like osmotics. Those are drugs that draw fluid into the bowel and they make stool softer and easier to pass. A lot of times, individuals might take a supplement of fiber, and that can be, there's a variety of fibers, and I've listed them here in parentheses. I want to point out the last one in particular. It's called sun fiber, and this is a hydrolyzed guar gum fiber. And it's different than other fiber supplements in that it's very, very gentle on the GI tract. And so from what I understand, it's really tolerable for people who maybe when they take regular psyllium fiber, they have some gas or GI upset and stuff with it. So just keep that in mind if someone has trouble with the regular fiber supplements. There's also stool softeners. Those are like the red caps they're like gel caps, and those are meant to soften the stool much in a similar way to osmotics. They're going to bring fluid in. And then we get into stimulants, and that is going to be like bisacodyl, senna, colonoscopy prep is a stimulant laxative. Senna, all of these are over the counter, actually. And senna is also a natural herbal treatment. You can buy Smooth Move tea, which can be used to help with having a BM. It's, that and prune juice. Those things are, just regular grocery store items that you could get or that a client could purchase to use to help them with regularity. Then if individuals have trouble with constipation, we may need to resort to a suppository that is a stimulant. Glycerin suppositories stimulate a bowel movement as well as bisacodyl, and they work in about maybe 15 minutes to, a few hours. And if those don't work, then we look at things like enemas. And an enema is a bolus of fluid that goes into the rectum, and those generally work very, very quickly. I also wanted to talk a little bit about some of the newer prescription medications that are available as laxatives. These are indicated for those who struggle with chronic constipation. It's a problem for these folks. And so they may be prescribed by their doctor something like Linzess or Amitiza, Motegrity. Lactulose is pretty common, but these other ones are fairly new. They can be difficult to get funded by insurance. They need usually a prior auth, but if somebody's having chronic repeated constipation or they have a history of bowel obstruction, and especially if they have like a neurodevelopmental reason for not being able to have normal bowel movements, some of these other drugs are going to work much better than the over-the-counter medications that you can get. Okay, so bowel protocol steps. So just real quick, the way these work is basically you would have something that the person might take every single day, like they have Miralax every morning, and that's to help keep their stool soft. And then if they don't have a bowel movement after a certain number of days, usually it's like 2 or 3, then they would take a PRN laxative. So maybe they would take some milk of magnesia. And then you would have step 3, and that would be, if the milk of magnesia didn't work within 12 hours, then you could give a different PRN laxative. Like now, maybe we're going to go to a suppository. And then if that doesn't work within, 4 hours, then we go to our third PRN, and maybe that's the enema. But that's kind of how a bowel protocol works. The important part about it, though, is to make sure that you have something that is routine, something that is an everyday thing. And the doctor can always put on there, hold for diarrhea or hold for loose stool. But if they have a history of constipation, they should be taking something every day to help with that. And you should also be doing other things to try and track their bowel movements, et cetera. And I'll talk about that in a moment. This was just an example, that kind of what I just went over. So the care provider's role, and I hope you can stick with me for just a few more minutes. I'm going to be super quick. So we want to make sure if someone has a history of constipation that we have a constipation care plan. And what would be in a constipation care plan? Well, first of all, we're going to address all of those common causes of constipation. How are we going to keep this client hydrated? For some clients, that may be just simply, I'm going to remind them every hour to drink some water. For other clients who maybe have more needs, maybe hydration has to do with giving them water into their G-tube on a certain, frequency, whatever it happens to be. How are we going to do it? What is the caregiver's responsibility? Diet. How are we going to improve this person's diet? How are we going to encourage them to eat more fiber or to eat more vegetables and fruits or cut out fried foods? What are our strategies going to be? Medications, what are the medications that they take that are putting them at risk for constipation? Are any of those very high risk for constipation? And, have we addressed constipation related to medication use? Stress management, same thing. We want, what are we going to do to help reduce this person's stress or help them reduce their own stress? And how are we going to encourage physical activity and exercise? So that's number 1, right? This is prevention stuff. Okay, number 2, we should be tracking bowel movements. We should be tracking bowel movements on pretty much everybody. And it doesn't mean that you have to be all up in someone's private space. If they're really independent and they can, manage that stuff pretty much on their own for the most part, maybe we're teaching them how to do their own tracking, or maybe we're just following up with them at the end of every day and asking them if they went to that day. How much was it? Did it look okay? Were you having to strain, that kind of thing. And then we want to make sure that every day we are reviewing the tracking sheet, that somebody's looking at it and actually saying, oh, look, it's been 3 days and they haven't gone at all. We need to look at what we need to do next. Oh, sorry. The next one is, following the bowel protocol. So maybe it won't be a step-by-step protocol like that, but you want to make sure that, your MAR is accurate, that it's kept up to date with the medications that are ordered. And then also that the staff is trained on the bowel protocol or the medication management that's been ordered by the doctor. So everyone knows what they're supposed to be doing and when they're supposed to do it. We want to make sure that we know what the signs and symptoms of constipation are that we're going to watch for, and include the signs and symptoms specific to that person. So if they had a certain particular set of signs and symptoms the last time they were constipated, we want to watch out for those types of symptoms in that person, Because sometimes people's symptoms are not really easily like to say, oh, well, this is definitely this. Sometimes it's not. And so if we learn, that this is how they act or what they do when they are really constipated, we want to make sure to add that to the care plan. We want everyone to know what to be watching for. And then somewhere in there, it should have like, what's their normal bathroom or bowel routine? Like, how often do they go when they're doing well? Like, what is their normal? Are they every 2 day person? Are they a every single day, every single morning person? Or, is it more like 3 days, maybe sometimes 4, which is a long time. But some people do go, 3, 4 days every time. We can have our non-pharmacological interventions on here. And that's going to be like, make some sanity for them at bedtime tonight because they didn't go to the bathroom today. Or, why don't you have a glass of prune juice with your breakfast? Or, maybe we're going to increase our physical activity today. We're going to go for a walk after dinner or whatever those things that are decided on by the team and by the client. Those are the things that we want to have in our care plan so everyone knows what the plan is. And then know when to seek medical attention and know what is an emergency. Everyone needs to receive training on this. As I said, we've done this bowel obstruction class many times. And the reason we do is because we still have clients who end up in the hospital with a bowel obstruction. We have clients who die every year from bowel obstructions. We have clients who end up with a colostomy every year from bowel obstruction. So this is really important. And that's why we do our training, but you are responsible for making sure your staff is trained. And especially if someone has a history and they have a constipation care plan, make sure everyone is trained on the plan. Okay. This is just an example of a bowel log. This is like one that staff would probably use if they were tracking. They might mark, how many times they went on the 3rd, on the 4th. And then you can look at this each day and see how long it's been since they went. And then this is another example. This is one where you could give this to a client, tack it up on their wall in their bedroom or in the bathroom, and have them just tell them, hey, just circle the one that matches what happened this morning, or write no, or, make it easy for them. I think that a lot of our clients could do that. But the key there is the staff has to check and see that they're doing it, right? Don't let it go too long before all of a sudden you're like, oh, well, they haven't really been writing it on there. And I have no idea when they pooped last, that kind of thing. So we want to make sure that we're still ensuring tracking is done, even if we are expecting the clients to be able to do some of it on their own. And then I also wanted to mention that for community care licensed residential facilities and adult day programs, you guys need to have a restricted health care plan. If the person requires enemas or suppositories, and they're in your residential home. I don't think that day programs need to worry so much about enemas and suppositories. You guys aren't going to be doing that at day program. But you do need to be aware that if somebody, is having symptoms or problems at program, you need to make sure you're letting people at the house know so that they can address it when they get home. And then if they do have a colostomy or ileostomy, a restricted health care plan is required at day program and at residential facilities that are CCL licensed. Okay, so that is going to be it for today. And I'm sorry I went a few minutes over. It's a lot of information, but I'm so glad that you guys stayed and hang out with me. Thank you. We will get your CEU certificates off to you. I usually do those Tuesday mornings, so I'll have those out to you next week. Did anyone have any questions or comments about any of the material that we talked about today? I haven't been watching the chat, I'm sorry. I'm looking at it now, though. Carrie says she worked with an individual before that had an ileostomy bag. It was not just a great physical change for him, it was mental, affecting everything. He ate, drank, a schedule of his feces, daily intake. Very, very hard for him. Yeah, that's absolutely true, Carrie. It is, I mean, just imagine if it was you, you know, imagine if you ended up with a colostomy, how you would feel, how that would impact your ability to function. Um, it's a lot, and it's really a lot for our clients. Our clients struggle enough as it is. They don't need further difficulties, you know. But anyways, I want to say thank you again. I really, truly hope that you all have a wonderful, wonderful week, and I'll see you guys next month.
Thank you, John.
You're welcome. Kiara and Paige, I don't know if you have an email or if you signed up through Eventbrite, I can get it from there. But oh, you're at RGL. We can just send it over there. That's fine. You don't need to put it in the chat. All right, Katie, did you get everybody?
I did.
All right, awesome. Thank you so much. I will see you guys later. Oh, there's Kiara's email for you. Thanks, Neville.